Welcome to AETCM, the Emergency Medicine channel. Today I'll be presenting a case of 20-year-old boy who presented to our ER with alleged history of deliberate self-harm by ingestion of tab verapamil 25 tablets of 40 mg dose. He presented to our ER within 2 hours of ingestion. So on arrival, we coming to 10-second assessment.
Okay. So I just have a curiosity. I don't think we came to know about the ingestion. Only after like 1 hour we got the information regarding the ingestion. So that is the most trickiest part of this case. Once we know it is calcium channel or beta blocker, it's very easy to manage. So then we can go through the guidelines. But here was the most important thing. It was not the presentation. Maybe for the sake of presenting, you have done this way. Actually, the boy came in with what complaints? He came in with some giddiness
and vomiting.
Some disturbance. And then he was brought into the ER and he was taken where the history of this ingestion was not told to us. That was the initial impression. Then we started evaluating him and we found out that his blood pressure was on the lower side and his heart rate was also on the lower side with ectopics. So this was the background, right? Then we took an ECG. So that's how we have managed. So when a patient comes in that way, when you will think, okay, am I dealing with a toxicity or it is something else, how will you decide? So that is a challenge. So how did you manage him initially before knowing this history? So you start from that phase. Then decontamination, then now later only we came to know. So how did you manage him initially when he came in?
Initially, he came to our ER with the complaints of 2 episodes of vomiting and giddiness.
Yes.
So on 10-second assessment, patient was seen conscious and cooperative. And then coming to the airway, it was patent. There was no secretions or gurgling. There was no pooling of saliva. Coming to the breathing part, air entry was bilaterally equal. He was maintaining a saturation of 98% at room air with a respiratory rate of 18 per minute. And there were adequate chest excursions. And then coming to the circulatory part, patient had a BP of 90/60. And then at that point of time, we had put 2 large bore IV cannulas.
Heart rate?
And patient had a heart rate of 60 per minute.
So that's the usual problem that we will have. So whenever we see 90/60 heart rate, so we need to 90/60 blood pressure, we need to have a higher heart rate. So for an 21-year-old boy, we are not expecting a 60 heart rate unless and until he is a regular, some physiological causes or he is on any other drugs. So regularly, if he is on any drugs like beta blocker, then we can anticipate. But 90/60, somebody is coming with, we need to think in terms what type of bradycardia is. So we need to take an immediately a 12 lead ECG. So that is the next step. So once you see 90/60, a borderline blood pressure, some symptoms, it is not an unstable. I will not say 90/60 is unstable, maybe a borderline. He can go into hypotension at any point of time. And the next thing is the heart rate is on the lower side. The next immediate thing, you have to look for whether there is any hypoxia. As you said, there is no hypoxia. You have to look in for the reversible causes. So that's the most important thing. So bradycardia, symptomatic and asymptomatic, suddenly he can have a syncope or whatever be the reason. The next important step is getting a 12 lead ECG. So what was the 12 lead ECG finding?
We had taken a 12 lead ECG. In that heart rate was persistently 60, showing a sinus bradycardia.
So sinus bradycardia with a heart rate of 60. Anything else?
QTC prolongation was there. It was showing a 580 QTC prolongation.
Okay. So for 580 QTC prolongation. So overall you can get QTC prolongation. In an emergency room you take a routine ECG and overall you can find this prolonged QTC. What will happen usually in bradycardia? What will happen to the QTC? Usually the QTC will prolong. That's a normal thing. What will happen to the bradycardia? QTC will decrease. So what are the reasons that you need to anticipate when the QTC is getting prolonged?
In case of hypercalcemia, there can be QTC prolongation. Then
what will happen to hypocalcemia?
QTC will be shortened. Normal or shortened QTC.
Okay, then.
Any toxins.
Then any toxin example?
Any antidepressants.
So there we talk more in terms of QRS durations. We don't specifically talk regarding QTC. When you take regarding tricyclic antidepressant or any, I will make this way, sodium channel blocker toxicity. Sodium channel. TCA is a sodium channel blocker toxicity. What are the other examples for sodium channel blocker? Sodium channel. Which is the sodium channel blocker? Sodium channel blocker, to be very specific. Which group of agent? Okay. Okay, then propranolol, that's a simple drug. Propranolol, carvedilol, phenytoin. Phenytoin. So that's the reason why we want to give a slow infusion for phenytoin, and we don't prefer to give phenytoin for a toxicology victim. Why? Because of this reason. When he develops a seizure. So phenytoin is another agent. So basically, when you say sodium channel blockers, they usually tend to increase the QRS duration. So ultimately, QTC will also be prolonged. So QRS is what, more than 100 milliseconds, more than 120 milliseconds, more than 150 milliseconds will be our concern. So typically, calcium channel blocker toxicity, typically when you say calcium channel, we cannot say calcium, it's always combined with beta blocker and calcium channel, almost the same presentation. It is almost the same presentation that you have. Again, calcium channel toxicity, you can have two different ways. What are the two different types of calcium channel blockers that you know?
Dihydropyridines and non-dihydropyridines.
So which category is verapamil?
Verapamil is a non-dihydropyridine.
So what is the difference between these two?
Dihydropyridines will be acting on the L calcium channel which is present in the vessels, vasculature. So there will be vasodilatation will
so
happen.
when a patient comes with amlodipine overdose, what will be the presentation?
Hypertension. Patient will be having severe hypertension due to the vasodilatation. Then
heart rate, what will happen?
Heart rate, there will be tachycardia will be
usually
there.
It will be tachycardia, and vasodilation usually cause hypotension. Usually vasodilation, it is hypotension. Hypo. Vasodilation is hypo. You said hyper initially. That maybe I heard that way. It is hypotension. So hypotension with tachycardia. And what does verapamil do?
Verapamil will be having hypotension and bradycardia.
Hypotension with bradycardia. So that will be the basic reason. So what is the reason behind verapamil induced hypotension?
There will be vasodilatation because non-dihydropyridines act on the cardiac musculature, causing vasodilatation can be there.
Vasodilatation.
Contractility also will
be. It is primarily more in terms of a contractility. So decreasing the inotropy of the heart. So when you have amlodipine, it has action on the alpha, and the other one you take it as beta. So that is very simple. So other one you can have tachycardia, this will be bradycardia with hypertension. So clinically it will be the same. So whenever you are getting a patient with calcium channel blocker or beta blocker does what? It decreases the inotropy. So that's the same straightforward. But the problem with these type of toxicity, usually the QRS, everything will not be widened. But whenever you are having a patient who is having a sodium channel blockade property, like as I said, these drugs, so then you need to think in terms of an TCA, like all those things agents. Similarly, sodium channel blockade can increase the QRS duration. So normally QRS won't be increased in these conditions. So that is the initial thing. So you had a patient whom we don't know what is happening. So as a clinician, what will I do next is, if the patient is symptomatic, I will go and give atropine. So this is how I will practice, right? So you are seeing a heart rate less than 40, 45, 50, and he's having hypotension. So you treat him like an unstable bradycardia. So you treat him like an unstable bradycardia, then only you will know what is happening. So what will happen to calcium channel or beta blocker toxicity? When you are having a young patient, you are not thinking in terms of an conduction blocks. Unlikely to have a complete heart block in this age. So always the reasons for that will be, what will be the reasons? Commonly is toxicity, and other thing can be due to any infection to the heart. Can be myocarditis, part of myocarditis, but here the patient was quite stable. So when you have a patient whom you are not knowing the reason for bradycardia and this presentation, and you are seeing hypotension and heart rate is further dropping, you definitely will give atropine. You will give 1 milligram of atropine. That's how we practice, right? So what will happen to this patient if you give atropine? There will not be much response. So that is the time when you need to think why that is not responding. So here we got a history maybe after 1 hour that he has taken some drugs, then we came to know. But in other condition where the patient is unconscious, he is not able to give you any history. So that is a very challenging situation. So this situation you need to address it. How will you come to a conclusion that probably this patient has consumed a calcium channel or a beta blocker, whatever be this? Similarly, we had a patient like 10 years back, a lady, she didn't utter anything to us. We were evaluating, we were thinking in terms of sepsis evaluation. Then later on we came to know that because amlodipine does what? You just imagine amlodipine. Amlodipine does what? It increases the heart rate and there will be significant vasodilatation. It will present like a septic shock. So what is this happening? Then later on, 24 hours later only we came to know that she has consumed this. So that's a huge challenge. But when we know, then we can just straight away go into a toxicological aspect, starting from our decontamination. But here decontamination again, GA decontamination, starting with the gastric lavage, after that this time of injection, it's not going to be helpful. So within 1 or 2 hours, definitely yes, we can give a GA decontamination. Maybe a dose of activated charcoal is also acceptable, but rest is nothing else is needed. Now we have confirmed that, okay, this boy has consumed this many number of verapamil. He has taken verapamil, and that is the reason for his hypotension and bradycardia we have found out. Now how will you address these two problems? What will you plan your management?
Initially, the patient was having hypertension and bradycardia. So for hypertension, we had given IV bolus of NS, 10 to 20 ml per kg we had given. That is 2 pints of IV bolus we had given for the patient. But the hypertension was persisting. So we went for an inotrope support, which has a...
See, I agree to the management, but what I'll suggest is that you put a large bore IV, immediately put your echo probe and see how is the heart and how is the IVC. Because that is the two things that you wanted to know. One is whether it is a pump failure, whether there is a problem in the contractility, or whether it's a problem in the periphery. So if it's a problem in the periphery, you have to give fluid. Imagine that you are having a very poor pump failure, like ejection fraction is very low, and you are again going to give him the fluids. So we know that this is a problem that we are having a patient who has taken calcium channel blocker toxicity. Even if he is a young male, he has taken a significant dose. So before you start an IV fluid, it is always preferable to just see the ejection fraction and go ahead and see how the IVC is. So IVC is quite, you are able to get IVC, very volume is low, you can give volume. But again, you said 10 to 20 ml per kg. Why you said 10 to 20 ml per kg? The reason behind that, whether there is an adjacent cardiac failure developing, we don't want that worsening. So otherwise, routinely we start with 20 ml per kg. So if you have doubt in your mind where you don't have echo mission or all those things available, what is the thing that you can do? Simple bedside test. Simple bedside test. Capillary refilling, again, it won't be a challenging thing. Straight leg rising test. So that is one thing that we can use, but contractility you will not be able to get. Straight leg rising test you can do and see how the improvement in the blood pressure is coming. So that will give you an idea when there is an increase in the venous return, there is some improvement in the blood pressure. So what does that give an idea? Okay, when you give this patient some fluid, he can have improvement. So that is how the idea. So when you have an echo machine, put the echo probe and see whether my idea is to give an inotrope or a vasopressor or volume. So 3 possibilities you need to consider. So good contraction, volume depleted, you give volume. Poor contraction, volume depleted, you can't give volume to him. So you need to give an agent that increases the contractility of the heart. So 90 by 60 BP, what do you wanted to start? You wanted to select an agent which increases the contractility of the heart as well as take care of the peripheral circulation also. So preferably which agent will be good?
Noradrenaline can be.
Noradrenaline don't have any inotropy. If the patient is having a 70 by 40 BP, I would have preferred to start noradrenaline. Because I need to increase noradrenaline peripheral vasoconstriction. Noradrenaline does what? It has got some negative, sometimes it decreases the heart rate. It won't have much effect on your contractility. So ideal agent at that time would have been epinephrine. Epinephrine is an agent or dopamine also. Again, dose dependent. 5, 10, 15. So you have to use something like 10 microgram to 50 microgram between, which has got inotropic contractility as well as got effect on the alpha. So ideal agent would have been an epinephrine. In that situation where I am saying contractility is poor as well as I am saying that there is peripheral vasodilation. So that will be an option. So that is the agent choice, not like routinely selection, you give noradrenaline for every patient. It's not like that. So this patient you have to be more active. Then the question arises, you have to think in terms of definitive antidotal therapy. So what are the definitive antidotal therapy that you know of? 1, 2, 3.
IV calcium gluconate can be given for the patient.
So how will you give calcium?
Initially, a bolus dose can be given. 30 ml of 10% calcium gluconate over 5 minutes can be given, and then we can check for any refractory bradycardia or hypertension persisting. If persisting, 3 doses can be repeated in the first hour. And then even if there is refractory shock, then we can go for infusion, keeping 0.5 milliequivalents per kg per hour.
What will be the target that you wanted of the calcium? It is ionized calcium, that is what we want to do. We are not going to check the serum calcium. It is ionized calcium, we want it around 2 millimoles per liter. So that is our target. So if you have calcium chloride, how will you plan it?
calcium chloride, the calcium content will be 3 times more than.
So one third
calcium
of whatever you have said for calcium gluconate, then you need a center line. So that's a problem with calcium gluconate and chloride. So our target is 2 millimoles, and you have to start on calcium. So that's the first therapy. So that might not be sufficient enough. So what is the next option that you
Next,
need to?
we can go with glucagon, where 5 mg bolus dose IV can be given.
So where will you give? Okay, this patient needs glucagon. He needs glucagon. That is a group of patient where I said whether there is pump failure with vasodilation. When there is pump failure with vasodilation, glucagon is a potential choice. But this fellow never had any pump failure. He only had a peripheral issues. So that way he would have responded with noradrenaline itself. So when you have pump failure, you have two options, whether to give glucagon or milrinone. So these are two agents. Milrinone is an ideal agent which it will again increase the contractility. So both acts by how? It increases the cardiac C amplitude, C amp inside. So that is how they act. So whenever you have problem in the contractility, you have to choose either glucagon or you have to use milrinone. What is the problem with glucagon? When you administer this, when you are giving 1 milligram for hypoglycemia, it's okay. This we are giving high doses, like you are giving 5 milligram IV you are giving, then you are giving it as an infusion. So problem, it can induce MSS. Suppose he has got a borderline sensorium and he can aspirate and he can further worsen hypoxia. So that is one major concern. So you have to have a borderline sensorium patient, you have to be very careful. But when you compare glucagon and milrinone, both have got similar effect, but glucagon is slightly superior when compared to milrinone. So that is the one agent. So where you will select for refractory hypotension, where it is a pump failure. It's a pump failure. It's not a peripheral issue, it's more into a pump failure. Then what are the other options?
Then high dose insulin euglycemic therapy can be given.
That's again one of the best therapy where your first two steps fails, then you can go for this high dose insulin with glucose, high dose insulin with glucose. How will you select?
Initially we give high doses of insulin as bolus, that is 1 unit per kg can be given for the patient, and following that 0.5 unit per kg per hour infusion can be kept for the patient, and then our target glucose will be between 100 to 200s, and then we have to look for the potassium level. It has to be maintained between 2.8 to 3.3.
Ideally above 3.5 is best. 3.5 somewhere around is the best thing.
And then monitoring of potassium should be done. Also we have to be monitoring for the glucose levels also.
Suppose I am telling this boy's sugars was 400. You wanted to give glucose?
No.
It is about 250, no need to give glucose. You can just continue with insulin. So the most reason why you are giving glucose is to prevent hypoglycemia. So the major important thing is insulin and potassium. So glucose we are trying to give to prevent hypoglycemia. So that is the option. So we didn't start this for him. We just started him on an noradrenaline and a calcium gluconate. He responded. What is the next refractory to this?
Then we, in case of persistent refractory shock plus or minus cardiac arrest, we can go for lipid emulsion therapy also. In that we give 20% of lipid emulsion, 1.5 ml per kg we can give for the patient in 1 minute, and then followingly every 3 to 5 minutes 3 doses extra can be given, making a total dose of 12.5 milli. It is the total dose in 24 hours.
Okay, so that is lipid emulsion. What else, if at all refractory?
Then we can go for transcutaneous, transvenous spacing.
It will not work.
Then extramembranal corporal.
This is ECMO. The next is the VA ECMO, veno-arterial ECMO. That is the only option, or intra-arterial counterpulsation therapy. And methylene blue has also been shown some evidences. When you go through the article, there has been some evidences for methylene blue also. So methylene blue also can be tried. And finally, the answer is ECMO. That's the only option that we have for this group of patients. And these patients will come out because within next 48 hours, the whole drugs will be eliminated. So any role for hemodialysis as such?
No.
It's not usually not done. And as I told, we can usually calcium channel and beta blocker will mimic. It will be almost the same. Presentation will almost the same. You will get the same thing only. But whenever you have doubt in your mind, as I said, no QRS duration prolongation, the group of drug like propranolol, it can have sodium channel blocker. That might sodium bicarbonate will help. So because sodium bicarbonate, just like we treat 3CA toxicity, soda bicarbonate will help in those group of patients. So whenever you get a beta blocker or calcium channel, almost the management is the same. But the only thing major difference is what will you might have is the whether the drug calcium channel blocker doesn't have any sodium channel blockers, but beta blockers, some of the beta blockers will have sodium channel blockade properties also. So that also you need to keep in mind. Nobody is going to come and tell you I have consumed 10 tablets of this and this is what they will present like a toxidrome. So toxidrome, when we say this bradycardia with hypotension. So when you are getting a bradycardia with unexplained hypotension in a young patient, always anticipate this group of toxicities. So that is the learning point, and I think he recovered very well with the calcium gluconate therapy and with your noradrenaline, and he responded very well. Okay. Anything else that you want to add on? So in a nutshell, calcium channel beta blocker toxicity or beta blocker. 1, 2, 3, 4, 5 points take home message you can tell me. What all things you need to remember?
Initially, we have to look for the hypertension or bradycardia. Initially, looking the cardiac status, IV fluids can be given, and if not responding, then we can go for an inotropic support. Then patient can be given, if the presentation of the patient is within 2 hours, then we can go for the gastric lavage or activated charcoal. Then if the hypertension is persisting, then antidotes like calcium gluconate can be given. Not responding, glucagon can be given. Even then not responding, then we can go for high insulin dosage with euglycemic therapy. Otherwise, lipid emulsion therapy can be given.
Finally,
Finally,
okay, fine. Thank you.